Professor Anand Chockalingam on cardiometabolic syndrome. And Professor Anand Chockalingam is a professor of cardiology and director of cardiometabolic program at CAMC Institute since December 2023. His research at the University of Missouri with over 70 original publications focused on premature heart failure due to mental and metabolic stress. He collaborates with mindfulness experts, behavioral psychologists, integrative medicine practitioners, and exercise and nutrition scientists to improve heart failure outcomes. He had pioneered in heartful living, advanced cardiac energetics, a novel self-inquiry, mindfulness empowerment program for virtual cardiometabolic care. He works with American College of Cardiology and several medical associations for building physician resilience. American Cardiac Energetics reverses biological heart age and premature heart failure by addressing the NASH and NAFLD, that is non-alcoholic liver disease, diabetes, hypertension, and inflammation. He is also a director of Diastolic Heart Failure Clinic and Cardiac Rehabilitation, where his team is exploring scalable integrative programs for heart failure and CKM metabolic syndrome care globally. I, on behalf of AVMC, warmly welcome Professor Anand Chockalingam to deliver a heartful, mindful speech this afternoon. Thank you. Thank you, sir.
Thanks so much, sir, for this kind introduction. Hello, friends. Can you hear me back there? The last row, you can still hear me okay? We'll go ahead and get started. If you can hear me fine from back there, we can continue, or I can put on this too, whatever you suggest. Okay. We don't want anybody sleeping post-lunch, right? Good afternoon. Yes. So, today we are going to do 2 or 3 things with magic. We are going to learn that magic is possible. We're going to see magic happen. And the best part of today's discussion is, I'm going to show you how it is done. So I want to inspire doctors to think outside the evidence-based Western medical system. We can do way better than that. It took me 20 years to say what I just said, but thanks to so many patients who have taught me medicine, cardiology, and mindfulness, today I'm able to come to you to hopefully inspire young minds to work in this integrative direction. So when I went to West Virginia about 1.5 years ago, I was in the local news saying we can turn the clock back. Is it good if we can get younger? How many would like to get younger? Anybody would like to get younger? Now you have to stand up and say, why? Because you are all young kids. Why would you want to get any younger than you are? Right? So who raised your hand? Why would you want to get younger? What is the hope? What is the ideal age to be forever young? We don't know the ideal age, right? As we were growing, I wanted to get older and mature. And suddenly I reached a point, I don't know which point, then I wanted to be younger. Life is always wanting, but I'm a cardiologist, so I deal with people who are dealing with a lot of heart issues and metabolic problems. They are getting closer and closer to losing their life. So if we can turn their clock back, it is not only quality of life, it actually gives them years of life back. So this is West Virginia. You see it color-coded yellow, not to highlight the state, but because it is the heaviest state in the United States, 50 states, heaviest state. And it is a rugged mountainous territory, so it's hard to reach everybody, and a lot of socioeconomic challenges also. So this is what we are trying to deliver in this community. An integrative approach where the cardiologist is just one more piece of the bigger puzzle. We need mid-levels, medical assistants, we need technology, we need the right medicines and procedures to give an ongoing improvement in clinical outcomes. Who is racing? He is not a superstar or anybody, but he is running, the red shirt is running a race, not against the yellow shirt. He is competing with the horse. You think it's even possible? Has anybody heard of this race? This race has been going on at least 100 years in several countries. It's about 35 miles of running in very challenging terrain. In the last 150 years, half the time, trained athletes are able to overcome trained horses. Half the time the horses win. 20-30 horses and 20-30 crazy guys do this race. Why I'm showing this picture is, anybody thinks they can outrun a horse in this room? I didn't know that race exists until I researched it. So human beings are born with that much capability. But if suddenly we want to become healthy and we start exercising, I don't think we are moving in the right direction. Because what I'm showing you here is there is a gradient of reduction. You see that? Initially, the risk comes down with the intensity, type, and duration of exercise. But within a few minutes, as you increase the level of exercise some more, what you are going to see is the risk starts again going up. So exercise is not just a simple prescription, it has to be individualized. But we as human beings are among the most endurance creatures ever to have lived in this earth. Okay? What I'm showing you here is CAD. People with heart attack, coronary artery disease, they are probably at more risk from the exercise even sooner. Because that original graph that I showed you is what science understands. But that doesn't calculate how much extra risk there is for people with blockages in their heart. And then the other one, HFpEF. Anybody in the back rows who knows what HFpEF is? You have to stand up and talk a little louder for me to hear. It's perfectly fine if you say something that is not right. HFpEF, in cardiology, what does that mean? Heart failure? Yeah, preserved ejection fraction. Have you seen patients with that? Many of the students today, are you in MBBS or what year, Tanvi? PGs. Excellent. So HFpEF is something that has only come around in the last 20 years. When I went to medical school in the 90s, when I was in your spot, this disease, this word did not even exist. The word did not exist, but the disease probably did, and it has only grown 100-fold in the last 20 years. How can some entity become so big? It is now 60% of all heart failure. It's not a rare genetic disorder that you do 20 different tests to find out. Out of 100 heart failure patients, 60 to 65 have diastolic heart failure, which we call heart failure with preserved ejection fraction. It's become such a big deal because people are living longer all over the world, and we are seeing more duration and severity of metabolic problems like hypertension, diabetes, and most importantly, obesity. Okay? In India, currently, HFpEF accounts for about 30 to 40% of all heart failure. In the US, it is 65%. Any cardiology fellows here, postgraduates, medicine residents, medicine PGs who've seen echocardiograms? What does this look like? It's a bad echocardiogram to have. Apical four-chamber view showing the heart plus what else? You're seeing a black space around the heart. What is that space? Cardiac fluid. In a patient who is short of breath, borderline blood pressures, admitted with heart failure type symptoms, this fluid means large pericardial effusion with cardiac tamponade. So this is what we want to discuss with the critical care team here, how our programs can make an impact, life-saving impact in people like this. If this happens in 99.9% of people, the immediate treatment is call the cardiologist, take the patient to the cath lab, put a needle, this fluid is gone, blood pressure improves. Sometimes we have to take the patient to the operating room and do a pericardial window. The fluid again is taken care of surgically. So the fluid has to be addressed right away. This patient in our university hospital in the capital of West Virginia could not undergo open heart surgery or go to the cath lab because he was 100 pounds over the cath table limit. So that is the hidden burden of obesity. Many people are led to die because they are unwell because of extra weight. This is the gentleman who has done this program, and within 4 months he loses 50 kilos. That's not the success. Within 4 days, this pericardial effusion resolved. So we took this story to American College of Cardiology and presented it as a highlight presentation for the first-in-man report of acute cardiac emergency responding to our integrative approach. So what are we doing to these people in 4 days that's making tamponade go away? We are connecting them with positive psychology, with their own, stress reduction and mindfulness practice. And we target natural ketosis. We are only now starting to scratch the surface on how powerful this ketosis can be. In the acute care setting, it made a life-changing impact on this patient because nobody could take him to the lab, and if he collapsed, went into cardiac arrest, doing CPR won't help because we are pumping from outside, but the compression is not reaching the heart because of the fluid around the heart. So we saved his life through advanced cardiac energetics. This gentleman went to 5 different hospitals. Ours was the 4th. He went to 3 more before he came back to us. He went to Cleveland Clinic, which is considered the #1 center for cardiology. And everybody refused to fix his aortic aneurysm. The aorta measures 6.5 centimeters. If the aorta ruptures, mortality is about 75% within minutes. Okay? But it is not yet ruptured, and nobody would operate on him because he's been in a wheelchair for the last several years. His normal BMI is what? Anybody remembers? Body mass index? Louder answer. 25, right? For him it was 70 in his 60s. So no surgeon, even at Cleveland Clinic, could operate on him. So we gave him our program. Within 1 year, I said he'll be operated. He outdid the expectations. Within 4 months, he became so fit that we operated on him in the 5th month, and we have published this at JACC, which is the most prestigious cardiology journal. Again, this is the first-in-man report of advanced cardiac energetics, making somebody who's inoperable a surgical candidate and getting the surgery successfully done. How do we do this? We use technology to monitor people at home, and we use semaglutide and tirzepatide as our guidance. Have you heard of those names? Ozempic, Mounjaro, anybody? Lift your hands if you have. Ozempic, you've heard that name? So these 2 drugs have become game changers. Throughout the world, people are lining up for these injections to lose weight or to control diabetes or to look younger than their neighbor, whatever reason. But for cardiologists, this has become the biggest challenge, is to optimize life, because already the heart has failed in heart failure patients, HFpEF patients. To give them a chance to continue living, we try to get these medicines. The challenge is getting these medicines. Even in the US, where patients have insurance, when we prescribe these medicines, 9 out of 10 times patients are not getting it. Because the copay, which is like 5%, is too much for many of the patients. This is the real world. Okay? But the evidence is these drugs work. This is a heart age calculator that has been around actually for 20 years. And it uses only metabolic parameters. Can you see from back there what I'm trying to show you here? Age, weight, blood pressure, do you smoke, are you diabetic? That's all. That's all we need to find a person's actual longevity from today's standpoint. So this works for people between the age of 30 and 70. If you have already had a stroke or heart attack, we don't use this calculator because the risk gets too high. And this gives about 5, 10, 15 years acceleration to most of the general community. Okay? Most people have biological age which is about 10 years older than it should be. Any questions so far? I think it's become too much of a monologue. We need to wake up the people in the back rows especially. Because I used to live in the back rows, go to sleep, especially after lunch. So far, you are with me? If you ask one question, then I'll know you are definitely with me. Somebody wants to stand up and ask anything related to what I might be able to answer. PGs, so far, what questions do you have? Smooth sailing so far. We'll keep going. And then we'll be done soon. Then I won't know what you liked, what you didn't like. So we insist on standing blood pressure. Today I am the only guy standing, whereas you're not putting your heart to any strain because you're sitting down. Okay? More than my heart, it is the entire autonomic system that is in stress for me to be able to stand up. I'm 6 foot tall. If my heart generates blood pressure of 120 millimeters mercury systolic, do you know how much blood pressure is reaching my brain? 120? No. At my foot level, 170, 180, maybe even 200 as I'm standing. But at the brain level, systolic pressure is only 90 millimeters mercury right now. If the pressure at the central level is only 110, my brain may be already hypoperfusing. I'm 50 years old. To stand up at 6 foot tall, does anybody want to clap that I'm standing up? Why don't you clap? See, this is the sad reality humanity is reaching. To stand up, it took us 100 million years of evolution. But that freedom to stand up, many people have lost. It's happened in the US, it is starting to happen in India. People think they are getting old or deconditioned and they ask for a wheelchair. People are afraid to stand up. They are on 3 medicines, 4 medicines for blood pressure, 2 medicines for heart failure. Standing up becomes near impossible for many people. Okay? So today you clapped. From tomorrow, you clap for no reason, right? Just because you wanted to be courteous to a guest speaker. But from tomorrow, at Vinayaga, I request you to ask all your patients to stand up to measure blood pressure. We made a mistake 200 years ago by asking everybody to sit down, breathe, relax, go into yoga, go into trance, meditation, then check blood pressure. If your motorbike or car makes some noise, will you stop it and ask the mechanic to fix it, or will you take him along and show him where the noise is coming? So the problem for heart, for the blood pressure is only when we are standing. Blood pressure is a challenge that manifests when standing. So check the blood pressure when your patients are standing. Okay? Will you remember to do that? Same way, weight and heart age, we'll not go into too much details, But it's a very simple metric. Based on BMI plus age, we say this is your weight age. Heart age, I just showed you the calculator. And then this is all at entry level. When people come into our office, we know their blood pressure, we know their weight age, heart age. And then this ABA calculator was published by Mayo Clinic, which is the Center for Diastolic Heart Failure. HFpEF was first described at Mayo Clinic 20 years ago. The same investigators are thought leaders. They talked about ABA, age, BMI, and atrial fibrillation. Just based on these three criteria, they're able to project the probability of diastolic heart failure. Okay? So that is what is the best metric so far. And our weight age gives the same thing without factoring in atrial fibrillation. So we've been at it now for 20 years. Mayo Clinic is now catching on with what we are comfortable labeling as obesity-related premature diastolic heart failure. That's what we've been talking about. What is heart failure? Trouble breathing, fluid backing up in the lungs, fluid backing up in the legs, and requirement for diuretics, Lasix. That's all is heart failure, okay? In simple terms. So if the heart fails because of alcohol or coronary events and bypass surgery and the ejection fraction is 20%, that's what we trained in over the last 50 years. But in the last 1 or 2 decades, what we are recognizing is about half the people with this clinical heart failure have ejection fraction that is normal, 55, 60, 65 ejection fraction. So that is what, when it happens at a younger age because of metabolic problems, we call it premature diastolic heart failure secondary to obesity. Okay? This is how we make people younger. Looking at their medical, social, genetic makeup. And this takes quite a bit of involved interaction with the patient, so much testing. This is how it looks in the real world. You can see this 34-year-old girl who has come to the cardiology clinic for 10 years, for high blood pressure needing 3 medicines, for angina needing 2 medicines, depression, anxiety, PTSD. Her heart, what do you think is her age? 63. A 63-year-old heart in a 33, 34-year-old girl who has three teenage children to take care of. She works in our hospital as a clerk. She's in tears when I tell her your heart is getting older very fast. She says, "Doctor, how do you make me healthier?" It takes us 10 months. It takes us 15 months to get the same woman transformed. Any drug does this? Any weight loss surgery, Manjaro, Ozempic does this? I don't think so. This has to be done only by one person, herself. But we being doctors, we can support her in that journey. And we can give her the right evidence-based guidance so that she will move safely towards better health. Okay? Her heart of 63 is now down to 30 years of age. She is now 35. So she's actually younger than her chronological age. She deserves your hand, not me. Do you want to clap for her? She'd love to come here and stand in front of you to inspire you. Her name is Liz Viken. She went on local television 3 years after the program and gave an interview saying that I don't fear getting the weight back. I don't fear needing those medicines again. And she has now learned and she is trained in our program. She teaches our program for anybody there. And now she's become the director of a fitness center in Columbia, Missouri, where I took care of her during this time. This is her teaching our course. So this certificate, called the ACE certificate, we'd like everyone in the world to take ownership for their life. That's all this certification is about. If we don't take ownership for our life, do we expect our parents, our children, our wife, or husband to take care of our life? Forget about the cardiologist and endocrinologist. They are too busy taking care of 100 other patients. Let us first take care of ourselves. Make sense? So this is the outcomes of what we have done in Charleston over the last actually 5 months of follow-up, 90 patients with heart failure, who have too many comorbidities. Half of them have lung failure, COPD, liver failure, smokers, kidney disease. Of these 90 people, heart failure should happen at what age? Average age of heart failure. Anybody? Medicine, PGs, what age is your heart failure patients that you come across? Usually. I'm sorry? 55. Yeah, you practice in India, I practice in America. Heart failure happens in the 70s in the US. In Japan, it happens in the 90s. In India, unfortunately, it happens sooner. We are at more risk for all these metabolic problems. India has 20% of the world's population, but heart disease in the world, do you know how much percentage is sitting inside India? 60%. So we are unfortunate being Indian, all of us. But can we do the best starting today for our own health so that we'll be there to optimize our longevity and health? So 52 is the average age of these patients in America. That is because this is very premature for US standards, and it's because in West Virginia there is such a high burden of metabolic problems, obesity, socioeconomic challenges. So we are seeing them at the age of 52. Make sense? This is the magic that I showed you, that I told you I'll show you. Weight comes down nearly 20% in 4.5 months. Cholesterol comes down 25%. Blood pressure drops 35%, systolic and diastolic. There is really no other program, no other procedure that drops blood pressure that much. 5% reduction is what you get with one medicine. Combination pills, you get 15% benefit. 35% blood pressure reduction, I've never heard of until these 90 patients showed me that that's what they experienced. Hemoglobin A1C of 10 becomes 5 within the same 4.5 months. So we know our program is magical, and this is not for those who comply, this is across the board. Okay? Has anybody heard of this CKM syndrome? Cardiovascular kidney metabolic syndrome. Has anybody heard of this program? CKM. This did not exist until 2023. The American Heart Association came up with a position statement that diabetes, hypertension, obesity, all these metabolic syndrome cluster is not in isolation. It is followed by coronary events and atrial fibrillation and stroke and kidney failure, but it is preceded by obesity. They said obesity is the starting point of all the metabolic problems that society faces. So based on this, one picture that I'm showing you here and this label called CKM, about 80% of the US population has to be on either Mounjaro or Ozempic. That is what this picture tells us. Okay? But we have known this for 20 years. So we are saying the AS program makes this one-way road go backwards. It's not a syndrome because even heart failure patients who went into heart failure last year, who had coronary event and bypass surgery 6 years ago, who had diabetes for 20 years, they can move in the right direction towards not better management, but even reversing these problems. And we have programs for heart patients or people pre-heart failure. They have fatty liver and metabolic problems like diabetes and hypertension for them. We call it the Heart Age program. And then we have student empowerment programs for teenagers and college students, which are empowered through students, so that they will never even need these medical interventions. So we are ambitious because we want to inspire the whole world in the right direction. And I'm going to stop pretty soon. So these are the last couple of slides. So this is the limitation of medicine: surgery, balloons, stents, procedures, injections, everything put together is only 20%. 30% is the mindset the patient walks into our room with. A whole 50% is their socioeconomic status. So if we want the future of one of our patients to be a little better, can we address anything beyond the 20%? our training, education, everything stops at that 20%, right? We become medicine, then we branch out into psychiatry or medicine or pediatrics or cardiology. All of these things is still within the 20%. This gentleman at 41, he has the clock ticking too fast. He has only 2 more years to live because his ejection fraction has gone down to 25% despite all guideline therapies. He's already on the best medicines. He's too heavy for any surgical intervention or bypass surgery or anything like that. He can't even go for the cath table. His weight is about 270 kilograms. The cath table stops at 180 kilograms, so he's about 80 kilograms over the cath table limit. So he does our program, and this is what happens to him. Charmaine Ganaway. He's very proud. He says, Dr. Chockalingam, you are moving from Missouri to West Virginia. I'll move with you and I'll help inspire your patients, show them how they can succeed. So this is what this patient is telling us. So we have so much knowledge we have gained from success stories of individual patients that we want to bring to our community here in Pondicherry. I'm going to stop with this last thought. This is tirzepatide, the latest, most magical opportunity to help people get healthier by losing about 15 to 20% of their weight. And this weight loss is sustained for months and years. This is published in New England Journal. The reference is here. Published only a couple of months ago saying Manjaro does magic. And this is how the magic looks. Weight loss sustains, right? I'm so thankful for this drug because it is legitimizing the weight loss that we are routinely accomplishing over the last 20 years. The problems with any procedure or drug is there is muscle strength that the patients are losing. Half the weight that is lost may be core muscle strength. There is a plateau effect beyond which the injection cannot let somebody go down. So something else has to happen on top of the injections. And that something else is what these 3 medical providers are trying to search. So that's what they're coming to us for. They are already on maximal Manjaro. They've already achieved some weight loss. They want to lose more weight and get more healthy. And then once you stop the injection, whatever weight loss will go away. The weight will regain. So these are the real world problems our society is facing. So I worked with this team for the last 20 years to learn how we can approach this in integrative fashion to actually deliver care for people on Manjaro, on Ozempic, who already had 2, 3 weight loss surgeries and who are dealing with cardiometabolic challenges that are limiting their quality of life and reducing their lifespan. So this is the program that took me 20 years to confidently say, yes, we can make you healthier and younger at no risk. So what I'm showing you here right in the middle is Dean Ornish. Have you heard of Dean Ornish, anybody? He's an internal medicine physician who taught cardiologists that atherosclerosis can reverse. He did this work 20, 30 years ago, and his program became the intense cardiac rehab program across the United States because he took care of Bill Clinton when he was the president. So this program has been in our institute for the last 15 to 20 years. To his right is Denise Chartas, who is the head of our cardiac rehab program in Charleston. So when I went and met her 15 years later, she said, don't bring wellness to us. We are the experts. We are in Charleston, the capital of obesity and metabolic problems. And Dean Ornish has personally taught us how to do intense rehab. And I asked her, forget about all your patients. How old is your heart? She's actually 60 years old, but her heart is 72 years old. So she teaches mindfulness, diet, exercise to thousands of patients. She runs the program. And her heart, despite Dean Ornish's intense effort, is 12 years older. So I told her, you do our program. Within 6 months, she did the Heart Age program, and she's turned 10 years younger in less than 6 months. So what does that mean to me? She has now become the head of our virtual home-based cardiac resilience program in Charleston. So this is what we are trying to inspire people at every stage of their life, from teenage throughout life, to move in the right direction and help ourselves, our families, and our societies become healthier places for us. This is my colleague, professor of heart surgery, cardiothoracic surgeon, who retired at the age of 56 because he was too tired, fatigued. He thought this is the end of the road. Once he loses 43% of his weight, he is now a new man. He has too much energy. So what does a heart surgeon do if he has too much energy after retirement? He comes back as the chief of cardiothoracic surgery. So if somebody in mid-Missouri needs open heart surgery, him and his team are ready to help. This kid is only 27 years old. At 27, I asked you how old people should be to have heart failure. Our PG said 50, 55. I'm showing you heart failure in the US in a 27-year-old. So I told you we use a metric called BMI and age. For him, his BMI was only 72 at the age of 27. So when you add 27 to 72, it comes to 99. So when you get close to 100, the weight alone is sufficient criteria to cause heart failure. So this is meant for the lay people to check it online and come to their doctor. Doctor, I've been on Lasix for 3 years. I have had trouble breathing for 6 years. Could this be diastolic heart failure? This is what the lay people should ask their primary doctor, who should then call the cardiologist and say, don't just do an echo for me, do a targeted echo protocol that will tell me if this patient has diastolic heart failure. Then there are certain imaging protocols, stress testing, diastolic stress test protocols, and cath protocols that we implement subsequently that clarifies the diagnosis and risk stratifies these patients. So for him, he was in the ICU about to die, intubated, with all the vital organs failed. So when he wakes up, he loses 30% of his weight in the first 4 months. But now it's been several years. He's now become the head of business there. He's thriving, he's doing great. He's lost about half his entire weight. He's just doing so well. One more last concept. This is the scary news that I bring to Chennai, because I've been meeting with some of the topmost liver transplant programs in the world. You know where they exist? Right in Chennai, liver transplant. And this is a sad story. Why is this picture sad? Because what I'm showing you is fatty liver, NASH, MASH related liver transplant was nearly zero 20 years ago. It's already 1/3. In the next 20 years, it is going to become 60% of all liver transplants. More than alcohol, more than viral hepatitis, our lifestyle is going to cause liver failure. Is there any medical treatment for liver failure? People just die. Heart failure, at least we have some guideline therapies. So this is our program, which is mostly technology based. We have medical assistants delivering it across the world for the last, I would say, 4 to 5 years. And in India, we are able to deliver this at much lesser cost than in the US. And this is the result in a small village in Namakkal. We see 50 kilogram weight reduction within 4 to 5 months. And this is life-changing for this 33-year-old gentleman. This is our actual center in Charleston, West Virginia, where we work with a multidisciplinary team to deliver these outcomes. And I'll stop here to see what we can discuss and move forward with. Thanks so much for this opportunity to meet some amazing minds. Thank you. We definitely need some questions now. Otherwise, it means that you all slept through the whole deal. Only the last 3 rows can ask questions. Nobody in the last 3 rows? Then I'll come with the mic to the last row. If nobody asks questions, I'm going to turn the lights and start from the first slide again. Anybody ready for that? Some questions, some interaction. Any row, anybody can ask. Enna Tanvi, at least you must ask some question if none of your students are asking. You like this discussion? What do you think you can do to your patients based on what I have discussed so far? Any counseling differences? Will you ask your patients how old they are and just go away with what number they tell you based on their birth certificate, or will you try to probe little further to find out their actual biological heart metabolic age? It's very simple. I showed you how you can calculate it, but it takes time. Everything takes another 30 seconds. But finding it is one thing, then telling the patient, counseling it right, all that we have to be a little nuanced. We can't just like that say, hello, you're 46 years old, but your heart is 70. It's not easy to tell a patient like that. So we have to become more bedside skills we have to learn so that we do it right. I would love to have some questions. PGs, medicine PGs, you cannot walk away from this without asking questions. This is related to cardiology, this is a big deal. Please stand up, ask whatever you like or whatever comments, thoughts, what you've seen. I mean, I'm showing you only conditions that you deal with every day, right? So the question was, tirzepatide, Mounjaro, what do I think about it? Till today, I've been lucky enough not to prescribe it to any of my patients. But many of my patients are already on it. And I don't have opinion one way or the other about it. But inside, I'm very happy that this drug is showing so much is possible. Because 10 years ago, 15 years ago, weight was considered as like height. Somebody's height is this, somebody's weight is also whatever it is. With that, we have to do whatever we can to help the heart or the kidney or whatever. But this drug said weight can be improved. So that's why I'm very happy that the drug has done what it can. But my reason for not prescribing it all the time is because my fear is really in a heart failure patient, if I use the injection and the patient loses more weight, what if and when the patient stops the injection and the weight regains, he'll be in worse trouble. So that's why I'm reluctant. But I've referred a few of my patients in the last 3 months to the obesity clinic to go and get this prescribed and monitored and tracked because I don't have the time to do all that. I don't think it's a bad injection. It's a very good injection, can make a lot of difference in some people. And I genuinely believe our approach, the AS program, can give a even broader benefit for a broader community. So that's why I don't use it on a regular basis. But I'm happy that these drugs are changing how not only the people, but also how doctors look at their diseases. Cardiologists look at heart failure. Gastroenterologists look at fatty liver. Nephrologists look at CKD. All of the specialists are, even orthopedicians who look at knee procedures, surgeries, they are looking at their patients in a different view because these drugs are changing everybody's game. So, I have not seen those reports, but these drugs are out only in the last 2 years. So it's very new. So the risks will accumulate over time. So if patients can come off the weight, that is important. But if we assume these drugs are doing something much more than weight loss, I am not buying that yet. So if we can achieve that weight loss, in an integrative, holistic approach and sustain that weight loss, that is priceless. If they can do it on their own, if they can do it with our support, with the support of medicines or surgery, it doesn't matter. The weight loss towards optimal weight removes excess inflammation in the system. That is what makes people biologically younger. So, make sense? Excellent. Thanks for that question. The only question so far. Any other thoughts, comments? Thanks so much. I thoroughly enjoyed coming and visiting. Thank you. I'm going to be around. If you have questions, you want to talk to me, I'm most welcome to address them. Everybody should hear us. Yeah, go there, yeah.
So I'm Dr. Sellu Pravin, first year General Medicine PG, sir. As Sarah has asked about the tirzepatide regarding the usage in obesity and weight loss, sir. And I've read some articles like there is a rapid rebound phenomenon, whether immediately if we stop the drug, the weight gain has been more. So how we can use the drug effectively in obesity for a long-term process in a weight reduction can be done in a slow way, like by preventing that.
Yeah, we should give him a big hand for this. See, these drug takes so many years, decades to develop. To bring them to market and show that picture that I showed you, they've spent millions of dollars on the few hundred patients to show that the drug allows weight loss. But his question is real world. In a study inside this room, inside controlled environment, it succeeds. But if you allow everybody to prescribe, the real world people to take these injections, what happens? That data will come out in the real world. It will come out as, because throughout the world we have more and more health information. So this data will be available only after 2 or 3 years. But his fear is once you stop these injections, for whatever reason, is there a significant weight rebound? The graph shows most of the weight comes back, but many, many people have rebound which goes even beyond. The weight regain is so high. In 20, 30, 40-year-olds who have other problems, it might mean that whatever better looks they had went away and they again have the joint pain and trouble breathing. But for heart failure patients, withdrawing these medicines and regaining weight can be life-threatening. So these risks are there, and the compliance with Mounjaro and Ozempic is at 7 months. So if you give it free of cost inside a research study, even then they are not going to comply. But in the real world, for 100 other extra reasons, people just stop these injections at 7 months. So that is a real concern. So if after 7 months we realize that drug is gone, the effect is going to go. We don't expect Lasix or propranolol or metoprolol effect to last 3 months after we stop the medicine, right? Same thing, Mounjaro effect also is going to go. That whatever original weight was will come back. That is the least. That is what we have to counsel our patients. But how many doctors are going to counsel like that? We are going to say, you take this, you're going to get better. That's all we say.
So many people are abusing these drugs, like many celebrities, they are using immediately for the weight loss, they are using these drugs without knowing the consequences.
Because we see real world patients getting admitted with hypotension, syncope, with the GI issues, with the gastroparesis, and gut ischemia, life-threatening problems from these drugs. So unless you measure, which blood pressure from today you will measure? Standing blood pressure. So if you measure that, you can at least catch some of these problems a little sooner. But if I want to talk about this one drug, I'll take all day, but I hope I answered some of the questions.
Definitely, sir. Thank you so much, sir.
Sir, I am Rohin Mehta, General Medicine first year PG. Sir, you explained about the exercise just now. Like it will increase the risk in few patients like CAD and heart failure also. So how will you define, how will you explain the patients to particularly which patient is doing what kind of exercise? Like we'll see now few cases, like someone is very good, perfectly fine, they are physically fit, and suddenly they will develop some cardiac issue and certain cardiac that is there. So how will you explain in term of exercise to the patients?
See, all these questions are million-dollar questions. My curiosity is, why did your madam have to force you to stand up to ask the right questions? She didn't tell you the questions. His question is, what is the exercise prescription once the heart fails? Is that right?
Yes, sir. Yes.
Very simple way.
Yes.
There is no exercise prescription for heart failure. In the Western universities, they are giving exercise for obesity-related heart failure. But because I have done this work for 20 years, I don't prescribe any exercise at all for several months until I'm confident, patient is confident, his family is confident that the exercise is safe. How to get that confidence, that's 1 hour discussion. Because exercise increases blood pressure, heart rate, arrhythmia risk, sudden cardiac death risk, not only for heart failure patients. For everybody in this room, exercise is dangerous. Then why do we generally recommend exercise? Because we are assuming we are all healthy. And to stay healthy, we need exercise. So cumulative benefit of exercise is more than the immediate risk attached with any exercise. So all of us have to be cognizant that we can't suddenly start running races with the horses. Okay? But for heart failure patients, we don't recommend any exercise for several months until they've already started our program and their confidence builds naturally towards safe exercise. And then we do the right stress testing, cath, whatever it takes to figure out how much the pressure in the heart rises, how much the pressure in the lungs rises, and then we tell them, okay, you can move a little further in your exercise. And what type of exercise? Walking is generally by and large the safest. Everybody can do it. Running has too many risks. The benefit is not that much more compared to walking. Then comes what? Cycling and swimming are nearly as good as walking. Cycling, swimming, walking are the best. When it comes to other exercises, I mean interval training, I mean weight training, and then bodybuilding, and all the fancy stuff that people are doing in the gym, all of that we have to look at it carefully, even in young people, even in people without heart disease. Once heart fails, I think it's not the time to start exercising at all. So be very careful how you prescribe this. Thanks for that wonderful question.
Thank you.
Quick questions, quick answers. I don't. Go ahead. No, any other questions? Yeah, please.
So Varun from Department of General Medicine. Sir, like in heart failure, what is the holistic approach if the patient has other comorbidities like chronic kidney disease, like liver failure, like that?
So 1/3 of heart failure patients have kidney failure. If you look at the liver function, it's going to be abnormal in 60-70% of heart failure patients just because the heart has failed. But if the underlying problem is metabolic, it's obesity, diabetes, hypertension, then good chance nearly all heart failure patients in that category that I deal with. I'm specializing in premature diastolic heart failure secondary to obesity. That's my area. And that is a huge deal. It's not a rare commodity. In that, we see too much of kidney failure and liver failure. Then there is management of those conditions, we let their specialists handle. So I take care of the heart. But because we have this integrative approach that allows people to get healthier, we have people on 40 medicines who are now needing only 2 or 3. What happened to the other 37 medicines for stress, anxiety, depression, for arthritis, for diabetes, for hypertension? They just don't need them anymore. So when the need comes down, we empower them to talk to their specialists, whoever prescribed whichever medicine, to go back to them and see if they can scale down. As far as specific treatment for cardiorenal syndrome, if that's what you're asking, there are 3 things that were tried. One is dobutamine infusion, another is ultrafiltration, third thing is Lasix IV continuous drip. Over 15 years, multiple millions of dollars were spent in multi-center trials using these 3. None of them work. So if there is extra weight in the body, we don't look at it as a problem, we look at it as the opportunity in cardiometabolic patients. CKM, cardiometabolic, all this come together. So we try to diurese them with minimal Lasix. So that is what we try to do. Anything else, madam? Excellent. Thanks so much. Yes, sir. Now we have to clap because you are asking a question without anybody forcing you to ask the question. Please stand up, please. No. Now we are opening it up for all off-topic questions. Why don't you give him the mic? Why don't you come up here so everybody can hear you better?
I'll speak. Yes, sir. So it's said that one of the reasons why people are collapsing, especially in India, I think you're aware how bad the COVID has hit India in the first and second wave. Even after complete recovery in young patients, it's been said that post-viral myocarditis is one of the reasons why people are having sudden MI. In young and fit people, what's your opinion about this? If you think it has got some causal relationship to it, is there any way young people or even interested people can find out if they are prone to it? How can we save ourselves from that?
Excellent question, and I don't know the actual answer. Okay? But my opinion is, I'm Indian, although I live in the US. So as soon as the pandemic started, I had chest pain. I did a CT coronary angiogram on myself in 2020. I wanted to be sure I was okay. Being a cardiologist, seeing this every day. Now 2 months ago, I played tennis. During tennis, I don't have pain, but otherwise I have little tightness. So I did my second CT coronary angiogram within 5 years, although I'm not diabetic or hypertensive, because that might be our only chance to make sure our atherosclerosis risk is low. Even after my angiogram being completely normal 2 months ago, today I can collapse and lose my life. That is the reality for any human being. Car comes with 50,000 kilometers, 5-year warranty. How many of us came with warranty? None of us. So every month I can do CT angiogram and still not catch it when it happens. Atherosclerosis is not a gradual progress alone. Immediate thrombosis can cause acute event that can trigger ventricular tachycardia, VFib arrest. Even without plaque rupture and coronary occlusion, there might be electrical foci and channelopathies that cause ventricular arrhythmias. Mental stress can cause. Have you heard of Takotsubo stress cardiomyopathy? Anybody? Nobody back there? Why half? So you've not heard enough about it. So I spent 15 years talking about Takotsubo all over the world because I was very fascinated by it. Last 5 years I don't talk about Takotsubo because Takotsubo stress, mental stress can make the heart suddenly weak. If for me standing up in front of all of you is stressful, my heart may already be weak inside. But because I've been teaching for 20 years, unlikely that today I was stressed. Make sense? But if somebody is suddenly put in a stressful situation, the heart can become weak and stop. This has been described for thousands of years all over in literature. But because we have echocardiograms for the last 30, 40 years, we've seen it as the apical ballooning syndrome. So there are so many reasons, it's only hypothetical, why cinema stars and celebrities and athletes suddenly drop dead.
Yes. I mean,
sometimes we don't know. And does COVID play a role? I definitely believe it does. Because across the board, coronary events, atrial fibrillation, heart failure, all these are cardiac problems. They've doubled in the community post-COVID. So that tells me that sudden cardiac death also is going to be significantly more. And in India, why does it happen in younger people? That is a question that nobody has so far answered. We've been looking at it, but I guess it's hard to find out. Genetically, we are more predisposed to accelerated atherosclerosis. That's all I can say. But what are the mechanisms beyond genes and lifestyle stress? Mental stress is much higher because of academic and social pressures in India compared to Western world. I don't know if that is some of the explanation. So it's hard to say what all are the underlying reasons. COVID has made it even harder for our people to cross their 40th birthday. So any Indian above 40, shake hands, wish them well for being alive. That is what the reality is currently. So exercise, in this viewpoint, exercise becomes even more dangerous. So first, get the patients to go through the right testing, to be confident their heart is good. I love to play tennis. Because my CT angiogram looked fine again 2 months ago, yesterday I played tennis.
Exactly.
Otherwise, sports is also a risk.
Because practically it is difficult for everyone to go through a CT angiogram and make sure that their coronaries are good. So I was thinking whether you have any insights like that. Yeah.
So there's no simple answer, but the appropriate testing for Indians especially is, I believe, CT coronary angiogram. To be genuinely sure there is no occlusive lesion, there is no calcium, and there is no soft plaque. So 3 levels we can exclude. And that gives as reasonable a confidence as we can get.
Sure. Thank you, sir.
COVID is one thing. COVID vaccine is another thing.
Yeah, even regarding that, yes, I agree. Thank you, sir.
Excellent question.
As a continuation of his question, young patients going in for sudden heart failure, can we have any marker to predict the heart failure? As we have newer markers for heart failure like ischemia modified albumin, heart fatty acid binding protein, and there are some technetium scans are available to view the viable myocardium, and fractional flow reserve we can find out. So non-invasive methods and using blood markers. In your practice, can you able to find out any patients at risk, like young individuals without any metabolic comorbidities, going in for heart failure or can go for heart failure, we can prevent them?
Excellent. So heart failure is, for the last 70 years, a clinical diagnosis. JVD, hepatomegaly, ascites, leg edema, crackles in the lungs, S3 gallop, that is what is heart failure. Trouble breathing, dyspnea, chest x-ray showing pulmonary edema. That has not changed. So heart failure, I'm glad, continues to be a clinical diagnosis. BNP, we've known, it's been around for ages. When somebody comes to us suddenly short of breath, to understand whether it is lung or heart, BNP is a tiebreaker. Within the heart, diastolic heart failure causes some BNP elevation. If it is alcohol or ischemic event with low EF, the BNP is, the normal BNP is less than 100. Up to 500 you can get with diastolic or with the lung disease or with atrial fibrillation. But if it's 5,000, 20,000, then it's usually systolic heart failure. But when you come to screening, I showed you our weight age, ABA, age, BMI and atrial fibrillation based Mayo Clinic predictor that was just published. All these things we are now trying to bring in to routine practice as screening tools. When people are referred to us for shortness of breath or leg edema, echocardiogram, 99% of the time the echo is going to be reported as normal ejection fraction, normal pulmonary pressures, no valve disease, normal study. But if you look a little closer, you'll see a little left atrial dilatation, you'll see little left ventricular hypertrophy, some diastolic dysfunction abnormalities. If they have HFpEF, majority of HFpEF happens still in older people. The one I'm focusing on is metabolic, obesity, premature diastolic heart failure. That the echo oftentimes looks completely normal. So what we do then is diastolic stress testing. We put them on the treadmill or the bicycle, push them to their maximum limit, and we look for wall motion for coronary artery disease, epicardial lesions. Then we look at diastolic function. We see some E prime changes, and we look for pulmonary pressures by Doppler. Pulmonary pressures normally should be less than 30 systolic. If it suddenly goes up to 50, 60, post-exercise, that means left heart failure is very likely. So putting all these things together, we say non-invasively. In the cath lab, LV-EDP is the best measure. And then again we give, in the cath lab it is hard to do exercise. Mayo Clinic does that, Cleveland Clinic does that, but we don't. have the ability to exercise inside the cath lab, but what we can do is give fluid challenge. Just normal saline 500 cc's, and we can repeat it twice. So altogether 1 liter, pretty fast, we give it to them. And then we see if the LV end diastolic pressure exceeds 18 millimeters mercury. If it exceeds, that means the heart has likely got a stiffness, diastolic heart failure. This is how we clinically approach. And then amyloid is a big deal now. People are looking for genetic variants, other things. Echo, MRI, stress echo, and then cardiac cath is what we are doing. Blood testing I am not doing for diastolic dysfunction because it is such a ubiquitous thing. Rare entities are still very rare, so we don't screen for them on a regular basis. Last rows, you have to prove that you are also awake. All the questions came only from the first 3-4 rows. Excellent. Thank you. Thank you.
So thank you, sir, for your wonderful lecture. It was eye-opening on cardiometabolic awareness. I think all our students have benefited a lot. Thank you so much.